So I'm going to start with an overview, and can I have my presentation, please? And this is the topic. I'm going to talk to you about bone loss around dental implant. Now, did you all enjoy the fireworks yesterday night, for those of you who've been in Camp Nou? I assume you did, because this is the last time you have seen fireworks, at least not in my presentation. My presentation is about the fact. My presentation is about the data. My presentation is about what we know and what we don't know. You don't care about what I think. I don't care about what you think. We only want to know what is the data. Let's go. These are some beautiful pictures of the city of Haifa, where I work. And we know that implant placement marks the start of chain of events that are associated with soft and hard tissue changes. Earlier on, we thought that this is a physiological phenomenon that has to accompany every implant placement. Nowadays, we think that maybe this is not always the case. Some of these changes might be pathological, and there are a multitude of factors that are affecting these changes. And in the next 19 minutes or so that I have left, I'll try to talk to you about some of those factors, because there are too numerous to cover them all in 20 minutes. So, placement protocol. We know that some implant and some clinicians are placing their implants supragingivally. There are some implants, like this one and others, that are designed to be placed supragingivally. In other cases, we are having implants designed for subgingival placement that we connect the healing abutment at the day of surgery, and they are healing supragingivally. Sometimes we place the implant, we cover them with the soft tissue, and only later on the second stage, we uncover them, and then we connect the healing abutment and the crown. Question is one superior to the other? Let's look at the evidence. Well, the evidence is not yet there. There is a systematic review published just a few months ago by Amri and co-workers that looked at the data. There are some animal study, there are some human study, but they cannot make sense, and making sense in evidence-based dentistry, they could not cumulate them into a meta-analysis. So it seems that there's no difference, but there is still no meta-analysis showing which is superior or are they equal. Second question is, where are we placing the implant shoulder? Do we place it subcrestally like here? Do we place it crestally like here? Or do we place it supracrestally like here, and everything in between? And even in the same implant, we can have some of the implant shoulder supra and some sub. So let's see what are the literature. What is the literature telling us? Felice Hovers and co-workers in their study concluded that bone loss was found to be greater in implants that were placed subcrestally. Makes sense to everybody, but I want you to look at their results, because sometimes it's not all about bone loss, especially in the anterior aesthetic zone. So you can see that this is the one group that was placed subcrestally, and this is the group that was placed crestally. While the group that was, where did I go? Right. So the group that was placed crestally has almost zero bone loss. The group that was placed subcrestally had bone loss that was much greater, 1.22. However, at the end of the day, the implants that were placed subcrestally were still subcrestally at the 1 year mark. So for those of you that are interested in aesthetic, so it could very well be that despite the fact shown in this paper, despite the fact you might want to place the implant subcrestally in order to preserve the aesthetics. In another paper, but this is a long-term study by Giorgio Romanos and his co-worker, he concluded that subcrestal or crestal, they did not have any difference in the amount of bone loss that was accumulated over a long period of time. And this is their graph bar to show that. And finally, a meta-analysis that was published by Frank Schwartz and co-workers has shown, however, that subcrestal bone loss does carry with it a greater likelihood of bone loss, which amounts to about additional 0.84 millimeter compared to crestal and supracrestal placement. So if you are into preserving bone, there's no doubt you need to put it crestally or supracrestally. If you're into the aesthetic zone, we can discuss it later on. Now comes the question of immediate, early, or late. And these are some pictures to wake you up. Penaroja and co-workers in 2016 had concluded that periimplant marginal bone loss between immediate and conventional loading were no different, which means there was no difference in bone loss based on protocol of placement. And even more so, Shingakalia and co-workers just this year even show some superiority to immediate loaded implant when used in an overdenture scenario, showing more bone loss in the conventional loading and less bone loss in the immediately loaded overdenture with locator abutment. Again, Romanos, in his long-term work, could not find any difference between immediate and late loading of dental implant. And in a paper we published in 2012, we looked longitudinally, prospectively into the chain of event around immediately and late loaded implant. And we think that maybe this is where the answer lies. It could very well be that immediately loaded implant has different biological healing compared to late loaded implant. And that's why in the early stages, there might be some differences. However, as Romanos and others has shown in their long-term paper, in the long run, they seem to be evening up. But of course, this statement has to be substantiated. And finally, in this meta-analysis, they could not show any difference between immediately and late loaded implants. So the state of the fact today is that we could not show differences in those two different loading protocols, and therefore, from a bone loss standpoint, they seem to be equal. Let's talk about environmental hazard, and that's smoking. Smoking is usually considered to be a risk factor for periodontal disease and for implant osseointegration, but is it a risk factor for bone loss? According to a paper by De La Rosa and co-worker, it's a major risk factor. If you look at the odd ratio, it's 39.6, which in plain English would mean that the odds of losing bone are 40 times greater compared to non-smoker in smokers. However, some papers seem to challenge this. And this is a paper coming from the group from NYC. Wagenberg is the primary author on this. And they could not find differences. If you look at the bone loss in their two groups, and this is a very large database, they had over 1,500 cases, you can see that the bone loss was 0.65 in the smokers and 0.51 in the non-smoker, and the statistical differences were not there. However, 2016, we had a systematic review and meta-analysis, and according to this systematic review, there is a difference, and that difference amounts to approximately 0.5 millimeter difference in the amount of bone loss than could be anticipated between smokers and non-smokers. Systemic condition. There's a lot to talk about systemic, and I don't have the time to do this, so I just put down a list. In the red, these are risk. In the right, there are not risk. And I just want to point out that osteoporosis, and this is a question that comes up, and I'm not to talk about bisphosphonate, bronch, and what have you. Just to let you know that either age nor osteoporosis is a risk factor for bone loss around dental implant, and this is something, and information you need to know, you need to be able to convey it to your patients. What about bone quality? Usually, I'm looking for high-quality bone. Usually, when I have a type 1 or type 2 bone, I'm happy. I can place an implant, I can good primary stability, sometimes if I need, I can immediately load it, etc. But what does this mean vis-a-vis the bone loss around dental implant? And now, if you want to look at the next slide, you're up for surprise. Because, according to this paper, published long ago, 16 years ago by Spray and co-workers in Journal of Periodontology, they have shown that bone loss around type 4 bone is less than type 1 and type 2. Type 4 had a mean of 0.53 a year compared 0.7 or 0.8 with the other bone type. Surprising? Maybe yes, maybe no. Maybe it has something to say about the importance or the hazards of having too much pressure in the cortical area when you place the implant. And this is not the only paper. Just a few months ago, Jomi, Ibanez, and co-workers have published a paper showing that not only does type 4 implant fare better than type 1, but actually type 3 fares better than type 1 as well. And you know, the magnitudes are not high, but these are annualized numbers. These are not all the time. These are annualized. And if you look at the proportion, so this is only 1/4 of the bone loss with type 1 bone. So, of course, I don't think we have anything to say about the quality of the bone. It is God-given, and this is what we find, is what we get. But just for those of you who open a site and find it to be a type 4, getting scared, there's no reason to scare. Maybe a reason to joy. I've covered several factors thus far, and there are many more to cover. At that point, I want to talk to you about those that I'm not going to talk about, and they are written here on this slide. Those with the yay and the nay, written in large letters, refers to where we have a definite answer the literature seems to be unanimous about. Those where you see a yay and a nay next to each other is where the literature is undecided, and the size of the font is where I think the strength of the evidence favors one or another. But as I said, this is a topic for a larger presentation. There are 2 or 3 more factors that I'm going to concentrate about. One of them is the quality of the peri-implant mucosa. There is a lot of commotion and a lot of papers being published about the quality of the peri-implant mucosa. And of course, this implant that I placed here in position number 22 is by far nicer than these 2 implants that I placed in position 24 and 25. The quality of the tissue here is much inferior to the quality of the tissue here. The question is not what is nicer, not even what is going to affect inflammation and peri-implant indices. The question is, how does this affect bone loss? There is one paper here by Ferreira and co-worker suggesting that if you have less than 2 millimeters of keratinized mucosa around the implant, that could be detrimental and will result in greater bone loss. Another paper by Bory and co-workers published long ago in 2008 saying just the same thing. And I want to show you the table from there, and I want to have a small discussion about the truth, only the truth, and nothing else. Because this is the way you all read this paper, suggesting that if you have narrow band of keratinized gingiva, you're going to have 50% more bone loss around implant. But I read it differently. And what I'm going to show you is from the paper. It's not something that comes from my mind. It's from the paper. However, they failed to include it in the table for one reason or another. And this is that. For some reason, the time frame was completely different, which means the follow-up on the narrow band was 5 years compared to only 4 years in the wide band. So I took the liberty to annualize the bone loss. And all of a sudden, it's 0.3 versus 0.35. I couldn't do the statistics because I'm not allowed to it without having the raw data, and nobody gave me the raw data. I just used the data that was in the paper, but suggesting that maybe the data is not as conclusive. Unfortunately, there was a meta-analysis recently published by Lin and co-workers in 2013, and they have shown that there is some extra benefit of 0.2 millimeter. However, as you can see, the paper by Burri with the inherited mistake in it is one of the major contributors to this meta-analysis. So the way I see the literature, the book is still to be written about the effect of keratinized mucosa on bone loss around dental implant. We still lack the evidence. Platform switching. Platform switching has been around for about a decade or so, and some papers has favored, some has not favored. Melanie and co-workers in 2014 has published a paper, and according to their paper, there is no effect. If you compare the regular to the switch platform, and you see the numbers, and you see the p-value, none of the switch platforms had superior bone response compared to the non-switched. However, we have published last year in CIDRR a paper where we have shown, this Dr. Guttmacher, my colleague, is the primary author on this, we have shown that site that had the switch platform abutment had only 0.14 millimeter bone loss in the first year compared to almost a full millimeter in the standard abutment. We call this abutment the tulip, but it's called, I think by MIS, this is an MIS study, SPK. So how come that we have two studies showing two different data? And then I looked at, just coming to this lecture, I decided that I'm going to look into the original Melanie paper. And when I look at the paper, I realized that their switch platform is very minimal. The mismatch of the width of the implant and the width of the abutment was very minimal. This is ours. You see, this is the standard, and this is the switched, and this is theirs. And then I remember a paper from 2010 published by Attier and co-workers where they have shown, and look at this, for those who had a switch platform that was greater than 0.4, the differences between groups were statistically significant, while for those where the switch platform was lesser than 0.4, these differences were not statistically significant. And to conclude this, Anibali has published a systematic review and meta-analysis, and the data is out. Switch platforms seem to have a 0.55 greater or lesser bone loss compared to standard abutment. What about implant geometry? My time is running out. So implant geometry has been studied, especially vis-a-vis the importance of the microthread. And you can see that even in one large as it is company, the implant design, geometry design is different because the book is not yet out, but basically some studies have shown advantage to using the microthread. Others have failed to show advantage to the microthread. And this systematic review failed to produce a meta-analysis, so the verdict is not out. What about the thickness of the implant facial bone? You can see that there are some studies suggesting that thicker facial bone is important to prevent further bone loss. However, some studies are inconclusive. This study is supportive of thicker bone having less bone loss, and also the one by Spray and co-worker suggesting that the thicker the bone loss you have, the lesser, or the other way around, the thinner, the lesser bone loss that you have. So where would you go from here? Actually, we don't know. We are hoping that maybe in the future, or in the near future, the V3 concept that suggests some innovating approach to bone preservation, bone loss, will show us that there is advantage to use this. I'm hoping that in 2016 or 2017, we're going to have the data, and I'm hoping that next time when I come to talk to you, I'll be able to talk about this innovating design of the implant neck, whether or not it helped to preserve and promote bone loss. I leave you with a picture taken from my window in Haifa, and it's not always winter, and it's also sometimes summer. Thank you very much.